We are live now.
Respected Chairperson, keynote speakers, renowned panelists, honorable guests, and the learned audience, good afternoon from Bangladesh. I am Dr. Sharmin Abbasi, Scientific Secretary, Endometriosis Adenomyosis Society of Bangladesh, and with me, co-moderator, Professor Shaheen Rahman Chaudhry, Head of the Department of OBGYN of Holy Family Red Crescent Medical College Hospital. Welcome you all to today's international webinar on adolescent endometriosis, a very important but mostly neglected chapter of womanhood. This scientific session, organized by Endometriosis Adenomyosis Society of Bangladesh, association with BD Physician and scientific partner Nuvista Pharma Limited. Participants across the globe attending via Zoom and social media platform. Endo March is Endometriosis Awareness Month. WHO states that 190 million women nowadays suffering with endometriosis, and among them, a big portion is adolescent. Fear, lack of knowledge, lack of awareness, social barrier, superstition, diagnostic delay, and huge cost of treatment, increasing this burden day to day. Our today's talk is the voice of adolescent endometriosis warriors at the aspect of prevention, early diagnosis, and management. Now over to my co-moderator, Professor Shaheen Rahman Chaudhry.
Thank you, Sharmin. We are just at the middle of March. Like all over the world, Bangladesh is celebrating Endo March with the slogan, Halt Endometriosis. Various awareness programs in the social media, webinars, as well as special services at hospitals, schools, and college ongoing. Ladies and gentlemen, good afternoon. This is Professor Shaheen Rahman Chaudhry, Executive Member of ESB. Once again, on behalf of ESB, welcome you all to today's international webinar on adolescent endometriosis, organized by Endometriosis Adenomyosis Society of Bangladesh. Endometriosis is an enigma. There is a diagnostic dilemma, debilitating disease, progressive disease, no permanent cure. All this creates a very challenging and difficult clinical condition, both for the patient as well as the caregiver. And moreover, when we are talking about adolescent endometriosis, it is even more challenging. Yes, today our scientific discussion is on adolescent endometriosis. Now I'd like to call upon Professor Saleha Begum Chaudhry, Founder Secretary General of ESB, for the welcome address. Madam, please.
Thank you, Professor Shaheen. Assalamu alaikum and very good afternoon to everybody from Bangladesh. I am on behalf of Endometriosis and Adenomyosis Society of Bangladesh. Welcome you all to today's international webinar on adolescent endometriosis, organized by Endometriosis and Adenomyosis Society of Bangladesh. And my heartiest gratitude to all for your kind participation. This special webinar is a part of celebration of Endomarch 2022, and our slogan is Halt Endometriosis. And this is fact that adolescent endometriosis has recently been a leading burden worldwide, mostly in Southeast Asia, including Bangladesh. ESB started its journey from January 2020, has been working relentlessly and organizing continuously programs on awareness creation, scientific session, collaborative work with other societies and international organizations, and also taken a school-based program. We believe that adolescent endometriosis deserve not just compassion, but to develop strategy, rational clinical approaches, and collaborative research to help work in early diagnosis and early intervention to halt potential progress of disease also possible infertility. We also believe that awareness and education, training and services will bring positive changes in adolescent endometriosis worldwide and also in the country. Hopefully, adolescent female will not be deprived of having good quality of life and a precious family, and also in the coming days, painless future. As a founder secretary general of ESB, I feel privileged to introduce two chairperson of this session, Professor Samina Choudhury, President, Endometriosis Adenomyosis Society of Bangladesh, and Professor Hemanto Senanayake, board member, Asian Society of Endometriosis and Adenomyosis. We have two keynote speakers, Professor Dr. Lon Hamel-Shoes from UK, publisher, editor-in-chief endometriosis organization, and Professor Deborah Bush from New Zealand, board member, World Endometriosis Society. And we have Professor Roshanara as a special guest, Vice President, Endometriosis and Adenomyosis Society of Bangladesh, and Vice President, ESB, and as a special guest of honor, Professor Gulshanara, Secretary General, Obstetric and Gynecological Society of Bangladesh. We have three renowned panelists, Dr. Narendra Malhotra from India, Vice President, Suffolk, and Professor Farhana Dewan from Bangladesh, elect President of GSB. And we have also Dr. Mike Armour from Australia, Ambassador, World Endometriosis Society. Ladies and gentlemen, senior professors, my colleagues, member of ESB and OGSB, new fellows, students, and all other connected with us from home and abroad. Welcome to today's webinar on adolescent endometriosis, a burning and challenging issue. Welcome to all again.
Thank you, Madam, for your kind and warm welcome. May I now request Professor Samina Choudhury, Founder President ESB, for her President remark. Madam, please.
Thank you, Dr. Shaheen. First of all, greetings from Endometriosis and Adenomyosis Society of Bangladesh. And I feel very much honored to be chaired with Emeritus Professor Dr. Hemanto Senanayake. And I also feel very proud that we have got a world-renowned personality in this occasion. And with us, you know, Dr. Deborah, Dr. Lon, Dr. Narendra Malhotra, Dr. Mai, Dr. Roshanara Begum, Dr. Farhana Dewan, and also Dr. Gulshanara Begum with us. And you know already our Secretary General has told you that this is Endo March. This is the month of endometriosis awareness. And we are celebrating it and we are observing it throughout Bangladesh, not only here, but here, there, everywhere. We are celebrating it throughout the world. And you can see that some of the activities has told by my Secretary General, but I want to highlight that this international webinar on adolescent endometriosis is a part of this program. And during this period, we have got different activities. Next, please. And we had a symposium and also roundtable conference. This is a brochure for adolescent reproductive health, and we had a roundtable conference with our different teachers and also other specialty. And this roundtable conference also published in our daily newspaper, and it also showed in our social media also, and there are national programs. These are few glimpses of it. And our national Professor Shahla Khatun was with us, and we have, with this also, we have celebrated Women's Day on 8th March. And this is that some our activities in different medical colleges, they also celebrated it separately among them. They had got the program of rallies and also the discussion meeting, and also they are in the road also. So I think that it creates a very good enthusiasm among our young groups, and they are committed to work on endometriosis. And this is our OGSB hospital. This hospital is by our OGSB members, Obstetrical and Gynecological Society of Bangladesh. We had this hospital with, these are few glimpses of it. So I think that we have, during these last 2 years, we have given a tremendous effort to create awareness among our groups. And we have also a research we conducted on adolescent endometriosis to create awareness in the school girls. And my request to Hemanta to include endometriosis and adenomyosis society in your Asian Endometriosis Society. And my request to World Endometriosis Society, and I first say thanks to them that they have included us as a member. And we also want to work with Deborah, Lone, Dr. Malhotra, and also Mike. We want to work together in academic activities and also in research activities so that we can combat the endometriosis and we can halt endometriosis together. Thank you very much for giving me the patient sharing. Thank you. Unmute Karo.
Unmute yourself.
Unmute,
madam.
please.
Unmute.
Thank you, Madam, for your very thoughtful and well-guided speech in this regards. You have highlighted what should be our focus, how we should approach these tender young groups and help them to guide confident and fight against this challenging clinical condition. Thank you, Madam, once again. May I now request Charmin to start our first part of the scientific session and introduce our keynote speaker. Charmin, please.
Thank you, madam. Now this is the time for core scientific part. First, the keynote lecture. Our first speaker is none. She is Lone Hummelschoß. Lone is not a doctor, but very close to the physician, and sometimes we make mistake for uttering her as a doctor. Lone is a well-known global advocate in endometriosis, known for her work in getting the disease recognized as political and policy level, both in the European Commission, Denmark, the United States, and the UK. She facilitates worldwide collaboration in endometriosis disease discovery and management among all stakeholders through her roles as Executive Director of the World Endometriosis Research Foundation. She is publisher of Endometriosis Organization and participation in multiple research projects investigating the improvement of diagnosis and management of endometriosis. Please welcome the most dedicated person who is working with most devotion for the distressed patient with endometriosis. Lone will talk on endometriosis starts in adolescence. Please welcome Lone.
Good morning from London, good afternoon to Bangladesh, and good evening to New Zealand and Australia. Thank you so much to the Endometriosis and Adenomyosis Society of Bangladesh for this kind invitation to present on adolescent endometriosis, or as I prefer to refer to it as the beginning of endometriosis. I want to just take this moment to congratulate the EASB for everything that you have achieved in the last 2 years since you were founded in 2020. Well done, and in particular for raising so much awareness during this month of March. Endometriosis starts at the beginning. This is from the Global Study of Women's Health, which was conducted more than a decade ago, where we saw that symptoms in most women start before the age of 30. In other words, it affects those during their prime years. Excuse me, I have a bit of a cough this morning, so I apologize for my
No
rusty
problem. No
throat.
problem. No problem.
But what is also important is that when a global consortium of investigators in endometriosis came together, they emphasized specifically that adolescents in particular, an underserved group with a high morbidity and social impact, and we are not really investigating this group, yet this is the age that is likely the window for the disease when it starts and when we should be intervening. I've borrowed this slide from Christian Becker with his blessing, and I thank him for that, which actually shows exactly that we perhaps need to take a step back and look both at fertilization and birth and the time before menarche, and maybe even before that, which I'll touch on again in a minute, where we're considering the risk factors such as family history, genetics, environmental exposures, other diseases, concomitant medication, and surgery. Surgery in itself could potentially be an insult if this isn't performed by somebody who specializes in dealing with endometriosis. And again, that very first surgery could result in repeat surgeries that again may contribute to pain. And when we're looking at the onset of symptoms, first visit to primary care, medical or surgical treatment, as I just mentioned, the wish to become pregnant or the inability to have children, and then looking at recurrence of symptoms and potentially other diseases as endometriosis progresses through the life course of the woman. I've messed with Christian's chart and added my own theories or hypotheses here, that if we look again at the life course of the disease and then the severity of this, it may very well be that it starts as very severe and peters out over the years. It may also be that it starts very severe and continues to be severe. And as you can see from the different blobs that I'm putting on here, that it is also perhaps manageable and won't progress significantly. It may also be that it progresses and then peters out. It may be that it progresses and does not peter out. So there are very many scenarios in which we can imagine that endometriosis that starts early can manifest itself differently depending on the individual woman. And this is described beautifully in the article by Grina Zondervan and her team in the New England Journal of Medicine in 2020, again, where we're looking at this life course, that we may have to look at fetal development when it comes to genetic susceptibility and the initiation and development of the disease before we see the actual symptoms of it and the struggle for a diagnosis, as we heard in the beautiful introduction earlier on. And some of these risk factors include low birth weight, small for gestational age, and Müllerian anomalies. Other risk factors when we move towards adolescence is the early age of menarche, low body mass index, and curiously, sun sensitivity. And I should know about that, being this very pale northern European woman from the darkness of Scandinavia. As we move into adulthood, those risk factors could be short menstrual cycles, increased menstrual flow, again, low body mass index, infertility, as I mentioned earlier. Possible risk factors include low waist to hip ratio, no or short duration lactation, dysplastic nevi or moles, consumption of red meat and trans fats, and endocrine disrupting chemicals, none of which have been proven, but they're out there as possible risk factors for endometriosis. So what causes the disease? And the short answer is we don't know. After all these years and all this advocacy, we still do not know. We have some theories of mechanisms the in situ ones, such as coelomic metaplasia, embryonic remnants, mullerianosis, as well as the transplantation theory from Sampson of retrograde menstruation. But none of these alone can explain why this disease develops and when it develops. There may be contributors such as altered cellular immunity, and one thing that is really worth noting here is that when it comes to adolescents, their immune system isn't fully developed yet, and therefore any insult that is thrown at it may not be fought against as much as in a grown woman. We have hematogenous, lymphatic, and iatrogenic metastasis, as well as genetics and familial history. And the question is then whether there is an insult with all of this thrown in together that makes endometriosis develop in some girls and women and not in others, such as environmental factors and such as diet, or as something we have yet to discover. So let's just take a reality check. We know that neonatal bleeding may be happening in 2 to 3% of girls and women. So that means that menarche is not when they have their first menstruation at, say, 12 or 13. They may have their first menstruation when they're born or just about to be born. So that may explain why, on relatively rare occasions, that endometriosis is found in those who've not yet had their first period, because actually they had when they were babies. As I mentioned earlier, the immune system is not fully developed in the adolescent, which may make it more difficult for the adolescents to fight the insults that are thrown at them in terms of endometriosis. And as I heard only last week at the very excellent Endo Dubai meeting from Philippe Konings and Stefan Gortz, endometriosis is at its most progressive in the adolescent. This is when the disease grows and matures into the disease that may only be found when that woman is in her 20s or 30s because of that very well-known diagnostic delay. And therefore, the risk of endometriosis increases with age, but it very much starts at the very beginning. And when it then comes to managing these girls, we need to remember that the sustained insult of a monthly period will continue to increase that pain because the nerve fibers in the abdomen will have this onslaught every single month, and they risk central sensitization in terms of pain at a later age if that sustained insult isn't managed very early on. Because at the end of the day, we are primarily dealing with pain, and the pain that these girls and women suffer on a daily basis. So the primary challenges in the adolescent is that many have primary dysmenorrhea, but not everybody has endometriosis. But we live in a society where pain is normalized, so it becomes difficult for these girls to get managed early on, and many at that young age may also be intimidated by healthcare providers, a little bit nervous about seeking that help and trusting those that should be looking after them. So, as I mentioned earlier, that early intervention is key to everything. However, early surgical diagnosis may increase the risk of repeated surgeries that then may contribute to that ongoing pain that may manifest itself as chronic pelvic pain later on. We therefore need to carefully develop proactive care plans, and my colleague Deborah Bush is going to be addressing that in a moment. What I just want to do during these last few minutes is to emphasize this incredibly unmet need of getting to the root of endometriosis. We need to develop a phenome of the different types of disease so that we understand how it develops and how we can identify subgroups and types of endometriosis to develop non-invasive diagnosis, targeted treatments, and, with all due respect to my learned healthcare professional colleagues, make you unemployed by preventing endometriosis and comorbidities in the future. And this is where the work of the World Endometriosis Research Foundation comes in with its EFFECT project. We have a mission of improving diagnosis, treatment, and prevention. But in order to do so, there's this huge puzzle that needs to come together, looking at disease mechanisms. Why do lesions develop? Why and how do they cause symptoms? And why and how do they respond to treatments? And everybody can contribute to that puzzle through collaboration with each other, through the utilization of standardized data and specimen collection, validated laboratory models, and robust study and trial designs. And this is why we've, developed standardized ways in which to collect detailed phenotypic data in endometriosis. So that's clinical data and surgical findings combined with standardized operating procedures for the way in which we collect fluid and tissue samples. This will reduce data variability. It'll contribute to global collaboration with large data and encourage really, really large scale studies to understand endometriosis better. WERF is now working with 51 centers in 22 countries, and the clinical questionnaire is available in 16 languages, with a couple of more currently being developed. That's Farsi, Polish, and Thai. I'm not going to read the list out to you. You can see the impact of this. So to summarize, we know that endometriosis is a complex and heterogeneous disease. It starts at the beginning, and it is likely more progressive in the early years than in later years. And yet the pathophysiology and natural progression of endometriosis has yet to be established. So what can we do right now? Well, we can listen to those with symptoms, and don't ever dismiss a woman in pain. She is looking for your help and assistance in dealing with this. I believe that early intervention, be that monitoring or management, is essential to avoid health issues in later life. And global collaboration is the very key to identify phenotypes and to develop targeted treatments and prevention in the next generation of women. And if you want to continue to keep up to date with what's happening in endometriosis, then these are my social media handles. Thank you very much for your attention.
Thank you. Thank you very much, Lone, for your extraordinary presentation. And you are talking about the evidence-based super talk. It actually based on you give the most important regarding the prevention of the endometriosis. And I think the whole world should focus on it, because the 190 million burden is a huge burden for the physician and also the advocacy worker. So you need to reduce the percentage of the prevalence. We need to focus on the education, learn, and also the evidence-based prevention protocol. It's really given a strong take-home message to our trainee. My hats off, respect to you for your tremendous works on endometriosis. And we have a question with you after the presentation of Deborah. I will take one question for you in here. So thank you again very much for your super talk in here. Thank you. Ladies and gentlemen, now we will going for our second speaker. Our second speaker is Deborah Bush. Deborah has a global influence on the promotion and prevention of endometriosis. She developed the world's first menstrual health and endometriosis program for school. She was honored bestowed on her by Queen Elizabeth II. She founded the World Endometriosis Organization to facilitate global collaboration and is a strong advocate for endometriosis. Deborah's many national and international awards, including the Commonwealth Award for Excellence. She is a board member of the World Endometriosis Society. Please welcome the most active and dedicated person who is working wholeheartedly with adolescent endometriosis awareness and school-based program. Deborah will talk on adolescent endometriosis, a shift in our thinking. Please welcome Deborah Bush.
Goodness me. Thank you so much for that really lovely introduction. It's a great honor and a privilege to always work with the Endometriosis Adenomyosis Society of Bangladesh. And it's nice to be here for me tonight, but for others in the morning and in the afternoon. Welcome to you all and thank you. I want to today challenge our thinking with adolescent endometriosis, and maybe by the end of my presentation, we might shift our thinking. So with that, I'm going to use also some of the wonderful slides and presentation from my dear friend and colleague, Lorna Hamiltoy. So are we talking about adolescent endometriosis? Or are we talking about adolescents who have endometriosis? That's a very subtle shift in our thinking, but nonetheless, I think one that we need to take notice of. So what type of endometriosis are we talking about if we speak about adolescent endometriosis? And I really want to thank Lorna for the use of this slide. I think it demonstrates very nicely what I'm about to say. So are we talking about adolescent endometriosis? And if so, at what age does it change? When does it change, in fact? Does it change at all? And are we talking about before 18 years or after 18 years when it becomes adult endometriosis? If it does change, why and how might that happen? And is it progressive? And I think Lorna has already demonstrated very eloquently this evening on how it may progress in this very vulnerable age group. So if we're talking about adolescent endometriosis, I want to ask you, what might be the defining symptoms? Might we define it as the ASRM staging system of endometriosis? Are we really talking about primary versus secondary dysmenorrhea? May we be talking about also knowing that the global prevalence of dysmenorrhea is between 45 and 95% of menstruating females, and the global prevalence of endometriosis in women and adolescent girls of reproductive age is around 10% that we know. So obviously there's going to be some with severe dysmenorrhea who have endometriosis. We need to shift our thinking. And I got some of this information from the ESHRA guideline of 2022. I want to introduce now two studies. I really like this study of 21,500 young women in the cohort. It was a systematic review and meta-analysis of the details from the study. Now, the one thing that really strikes me out of this is that we have 71% of our under 25s with dysmenorrhea. That didn't matter at what part of the world she was in, and that is a statistic that we must make note of. Further, in this very nice study from Australia with 4,200 young women aged 13 to 25, the conclusion here was that the prevalence of dysmenorrhea was high, irrespective of her country, and had a significant impact on her academic performance and at school and at higher education. These are important large cohorts that we must make note of. Then further, we also know that adolescent females with severe dysmenorrhea have disrupted development, interrupted education, missed job opportunities, and emotional, psychosocial, physical, and mental health outcomes. Lona alluded to this very nicely in her talk, really explaining to us what can happen to a young woman when she's not believed by her doctor or feels that she can't go and discuss her menstrual concerns. It doesn't take too many bad periods for these very young girls to feel that they really are not coping. And in fact, that can then lead to a chronic pain situation or central sensitization, as has been discussed. We know globally that school absence with dysmenorrhea is 20 to 31%. In this very well-known menstrual disorders of teenagers study from Canberra, we had 25%. In our own study from the Me Education program, we found out 27% of girls often or always miss school due to dysmenorrhea. So that you can see that globally and in other studies, we're stacking up with the same outcome. We've got about a quarter of our menstruating young females who are affected by dysmenorrhea, many of whom will have endometriosis. So we know that early recognition of symptoms and timely intervention is key. We know that education is the best screening tool available, and we're talking about a multidisciplinary treatment. And I want to get on and show you now a case study highlighting a very young patient of mine recently. This is about Janie. She's 18 years old. You can read yourself about her childhood. Her mother also had advanced stage 4 endometriosis with an early hysterectomy and bilateral oophorectomy. Let's look at what happened from menses at 12. I won't read out all the debilitating symptoms. You can read yourself from this area here. But socially, we can also see that she's now absent from school and withdrawing from many of her social activities. She's 12 years old. We can also see now that at 13, multiple presentations to emergency department and GP, she was prescribed combined oral contraceptive pills and non-steroidals. She was on regular tramadol and oxycodone by 14. She was becoming withdrawn now and absolutely isolating herself. The laparoscopy she had at 14 was unremarkable, negative for endometriosis, and yet her symptoms continue unabated, but with growing mental health issues. What do we do next? We will all have seen young people exactly like this. Now, bearing in mind that her laparoscopy was unremarkable and negative for endometriosis at that stage, I want us to remember that. So what happened to Janie between 15 and 18 years old? Well, let's look at this. Look, I'll go quickly. 2 colonoscopies, a gastroscopy, scans, bloods, all unremarkable. She was reviewed by a gastroenterologist, an endocrinologist, a clinical psychologist, a pelvic physiotherapist, and a dietitian. She followed a FODMAP-friendly diet and gluten-free diet, but her symptoms worsened and intensified. The medical cocktail now included antidepressants. Janie was able to maintain academic studies, but has withdrawn from everything else. That was because she had very good home support. In August 2021, her father contacted me. He was desperate to get her some help. I referred her to a colleague with expertise in endometriosis, who was also an advanced laparoscopic surgeon and a key advocate for a multidisciplinary approach. In September 2021, look at the result. She had another laparoscopy and severe stage 3 endometriosis and adhesions were confirmed, and the gynecologist wrote on her surgical note, painstaking excision. Now, let's not forget that she had a laparoscopy that was unremarkable. So had her parents not proceeded to get expert advice and help, 3 years down the track, what might have happened to Janie? It is inconceivable that then I put it to you that maybe endometriosis was not seen or identified at 14. Or maybe it was not seen because the gynecologist was a general gynecologist and not an advanced laparoscopic surgeon. We won't know. But even in the event of a negative laparoscopy, please don't rule out the chances that this young woman may have endometriosis. So what's happening now? Well, very quickly, she had laparoscopic surgery to fully excise the disease, adhesions removed, and a JDS placed. We're following a multidisciplinary approach, and I was absolutely thrilled to bits when her mum wrote me that lovely letter. Next steps, we're taking a breather. We're going to follow a multidisciplinary treatment if symptoms persist. So what do the guidelines say then for the treatment of endometriosis in this age group? So I've sorted out some guidelines for us to look at today. And the first one I'm going to draw your attention to is the one that I was insistent on New Zealand getting, and work with our Ministry of Health and key stakeholders to form a task force to make this happen. We've now got the diagnosis and management of endometriosis in New Zealand. It's available on the Ministry of Health website. Look, another very good guideline that came out after this that I know Dr. Mike Armour was involved with is the RANSCOG guideline. Then again, the NICE guideline from England on endometriosis diagnosis and management, the consensus at West document here on current management of endometriosis. And the one I'm going to use this evening looking at endometriosis in adolescent management is the ESHRA guideline. That's the newest one on the block, and that's the one I'm going to draw attention to. So the guidelines, I think we can summarize them as all saying we must intervene early, we must recognize the symptoms early, intervene in a timely manner to stop the disease, one, progressing if possible, but to manage her symptoms well so her lifestyle and schooling are not compromised. So the endometriosis in adolescents chapter, I'm urging you to go to the ESHRA guideline and have a look. What does it say first? It says careful history taking, positive family history, and looking at absenteeism for school, all very key when you have your young person in front of you. Please then look at the symptoms suggestive of endometriosis, and you can run through these yourself. I don't need to read them out. They will be well known to you. And then this one I am going to speak to, age and cultural background and acceptability before performing a vaginal examination. That's what the guideline says. But I urge you to think about the management of these young girls and the importance of making sure that you've not just had consent, but it's right for this very young, vulnerable girl. We don't want to add and contribute to her mental health and her well-being by intervening in something where many of these youngsters have stage 1 disease, and we're not often going to find anything on vaginal examination. And I'll allude to that very soon with a graph. But it does recommend to consider transvaginal ultrasound if appropriate, or consider MRI, transabdominal, transperineal, or transrectal. It also looks at the clinical symptoms at chapter 5 again. And what they're saying in the ESHRA guideline is that it may be more varied in this age group. And I think, Lona, you touched on this a little in your talk, that we must be thinking about, we're thinking this in our older age group, but are we actually thinking that it's actually more varied in this younger group? So what does the treatment say? Again, using the ESHRA guideline, chapter 5, pages 78 to 84. What it is saying is non-steroidals associated pain in adolescents with suspected endometriosis should be tried first. But another cautionary warning here about NSAIDs, please make sure that this young person is well monitored on them. We don't want them to end up with continuing gut problems down the track. Hormonal contraceptives, and I was so pleased to see that they've got Progestins as a first-line treatment in the ESHRA guideline. We brought this out in our own New Zealand clinical pathway, and it's thought to be effective and safe. Laparoscopically confirmed endo and associated pain, where that hasn't worked, you may consider GnRH agonists for up to a year with ADVAC therapy. Again, in the ESHRA guideline, consider surgical removal or excision of endometriosis lesions to manage the symptoms. However, they're saying the symptoms may be considerable, especially if the surgery isn't followed by hormone treatment. And it may be recurrent disease. And I think that's something we must make the first surgery the best surgery, so that we're not having repeat suboptimal surgeries for this patient. It should be performed laparoscopically by an experienced surgeon, an advanced laparoscopic surgeon, and if possible, remove all the present endometriosis. And then we should consider post-operative hormonal therapy, as that may suppress recurrence. Well, I know in our work that we've done here, we've got low recurrence rate, but then all the endometriosis surgeries are done by advanced laparoscopic surgeons. I was very surprised and somewhat disappointed that the ISHRA guideline in this age group did not mention well health for well-being coaching, which is my private practice, or a multidisciplinary treatment approach for this age group. I urge you, it's just as important for this age group as it is for those with endometriosis who are older. And we're talking about pelvic physiotherapy or clinical psychology or a dietitian if her bowel-related symptoms are particularly bad. So this is our endometriosis centre of expertise, where I work out of as well, Oxford Women's Health in Christchurch, New Zealand. We're very proud of our building. It grew from the ashes after the Christchurch earthquakes. And speaking of earthquakes, I'm going to present this slide. Here we've just got a bunch of earthquakes where I lost data, so that's why there's a gap there. I have presented this slide before, but I think it's very good because I want us to look at this longitudinal study that I did actually with Dr. Michael East at Oxford Women's Health, where we studied our youngsters presenting. So this is the under 20 age group from 2001 to the end of 2015. And you can see this growth of presentation here if we follow this trend line up to the end of 2015. And what was the reason for this great influx of youngsters presenting? Well, this is the area that the ME program in schools has been running for 22 years. And it's not unusual for youngsters to say to me, we heard the ME program at school, and that's why they're presenting. Remembering that this is a specialist referral centre and not a public hospital. Having a look at that peak there, 96% went to laparoscopic review, 98% were diagnosed with endometriosis. They'd all been on other management first, but had not done so well. So I understand it's a biased cohort, but nonetheless, a very good example of what we may find in this age group, with 49% had stage 1 endometriosis. So let's now look at some of the symptoms. You know, you won't be surprised at these at all: dysmenorrhea, lower back pain, bowel symptoms, bloating, fatigue. I can tell you too that at the end of 2019, 62%, so this figure had grown. And interesting, look at this. In the 31 to 35, less presenting here, which is what we want to see, and more presenting here, which is also what we want to see. And I also want to have a look here that the ISHRA guidelines states very clearly that all forms of endometriosis have been found in adolescents. So let's check that out now with our own internal audit. Just looking at advancing the presentation. So the stage of endometriosis diagnosed in patients under 20 years, here we go here, 49% stage 1, 28% stage 2, 16% stage 3, and 7% stage 4. I want to just quickly refer to this 7%. One of these youngsters was 14 years old with advanced stage 4 endometriosis. So we do find it, but does it progress in this age group, as Lona was saying? Well, let's look. What was the treatment first off that we provided? Laparoscopic excision, plus or minus Mirena or JDS and other hormone treatment, and always a multidisciplinary approach with specific and very careful management of this age group. Just having a quick look at the difference between the patients in the 30 to 35 age group, far less with stage 1, far more with stage 3 and 4, and of course then they're also presenting with fertility problems. This is what we must stop and work towards. So I'm showing you here young Laura, who's 15 with very mild inflammatory stage 1 endometriosis, and Lisa, 32 years old with advanced stage disease, asking you who had the worst pain. Well, we don't know. We can't see pain. Clinically, Lisa obviously had the worst disease. So I ask you again, can we stop this from becoming this? We think we can. This is about the Me Education program. In the interest of time, I'm not going to dwell here, but I do want you to say that it has had a major impact on the early presentation of symptoms and timely intervention in this young age group. And you're welcome to go to the Ansdell Journal and look it up and find out for yourself. So I urge all of us, please, for those with endometriosis or those who you think you have a suspicion that they have endometriosis, early recognition of symptoms, empowering our primary healthcare practitioners to make a suspected diagnosis and commence management, an appropriately trained multidisciplinary workforce in secondary and tertiary care, and improved equity of access and health outcomes for patients. And let's not forget what the World Health Organization are now telling us. Let's make sure every person with endometriosis gets the diagnosis and care that they need to manage their symptoms. And they go on to say, it's not just a matter of health and well-being, it's a matter of human rights. I think we do need to shift our thinking to adolescents who have endometriosis and manage them appropriately. And I do hope that some of these suggestions that I've made this evening will have an effect on your thinking also. I would like to acknowledge and thank the organisers of the Endometriosis Adenomyosis Society of Bangladesh, EASB, for your tireless work, your incredible efforts. I've watched you on social media. It's absolutely impressive. Thank you for your commitment to this age group, for this webinar this evening, and for all you do. And I make special mention to Professor Chowdhury, Dr. Seninyaki, and Dr. Shameen Abbasi. Thank you very much to you all. And a quick look before I go, love to see you all in Edinburgh at the World Congress on Endometriosis 2023. It's important to me as a board member to invite you there and welcome you with open arms. And I hope we do get to meet in person. Thank you very much.
Thank you, Deborah Bush, the madam, for your actual wonderful presentation, madam. And your talk gave us a new horizon of thinking and rethinking about the diagnosis and the management of adolescent endometriosis. You truly mentioned, madam, the chapter 5, the new ESHRE guideline that is published in the 2nd February 2022. It gave us many new information about the rethinking for the diagnosis and the management of the adolescent endometriosis. My hats of gratitude to you. Let's work together to combat adolescent endometriosis. Now I'm taking just 1 or 2 questions because due to the time screening, not very much question I can take. I just take 1 question from our friend, Sonia Gorver. She also joined with us and she asks to Deborah that, how do you know whether it was the surgery or the post-operative hormonal treatment that resulted in the resolution of the symptoms of endometriosis and better long-term outcome? Would you please add, madam?
Yes, I think you're referring to my patient, Janie. in that case study. So I can tell you that endometriosis and adhesions were wrapped right around her bowel. It was very difficult dissection. She had infiltrating disease over pouch of Douglas, uterosacral ligaments, right over the, absolutely all over the peritoneum, infiltrating, as I said, and it was mainly the bowel was already hooked up with significant adhesions up into the pelvic brim and right down deep in the rectovaginal septum. So when she woke up, it was almost instantaneous. Now, how do we know? Well, we'd be hard pressed to say that was 100% because of good surgery and good management, but I put it to you that it was.
You absolutely rightly tell about it. And for the adolescent endometriosis, actually for the long term, we need the suppression therapy because she will go for the reproductive age and after that, everything will happen. So prevention of the infertility, one of the main concern of our management. Yes. And another question for Lone, for you, that is the cost and superstition for dealing with adolescent endometriosis is one of the major barriers. Especially in the developing country. So what is your opinion that how can we overcome it? Because a long-term treatment, many cost-effective treatment, sometimes it will be difficult for the parents to continue it. So from your point of view, you are working as advocacy, you are working with the policy. So from the policymaker's point of view, what's your opinion, madam?
I need to just really emphasize here that I am not a physician. But I think Deborah touched on this beautifully, and that's the use of progestins. It's a very cheap option. And what I have heard in other presentations, and again, I refer to Professor Koning's and Professor Gort's presentations a couple of weeks ago in Dubai, is to titrate progesterone. So they don't necessarily need the full dose. But figure out which dose works for that woman to temper her symptoms. And that could be a very cheap and easy options with very few side effects. And the same goes for the birth control pill. They may not even need a full tablet. They may only need half a tablet. And here I refer to the presentation by Dan Martin, who is probably known to everybody in this forum. So I think it becomes a matter of figuring out what works for that individual girl or woman to have some sort of sustained way to temper her symptoms and to reduce that onslaught and insult so that she doesn't end up with chronic pelvic pain because she's had brutal periods since the age of 11 or 12. I hope that answers your question.
Do you think, madam, that in here we can include the supports from the government to give some drugs that is without cost or free supplementation of the drug? And sometimes we do think that in the curriculum of the textbook, we need to include the endometriosis and the menstrual health together. What's your opinion?
Absolutely, and Deborah Bush described that beautifully. We have an impact on society. Again, work that's been done by the World Endometriosis Research Foundation shows that the cost to society, not just of treatments, but from absenteeism, is really, really significant. So for me, I think it should very much be a matter for governments and policymakers to ensure that those with endometriosis or suspected endometriosis or pelvic pain for that matter is taken care of early, and that is done at the expense of the healthcare system and not at personal expense.
May I also add to that? I think that one of the, in response to the question earlier, and it does go on from what Lorna has just said, is that let's not forget the importance of the patient in this. The patient was so excited to have a diagnosis, to have her disease treated. So that in itself was, was it, you were asking the question, was it the surgery that actually worked? Well, for the patient, it was the surgery that worked. And if it worked, then that's a great thing, not to mention the skill of the surgeon. So I'd just like to say, we often forget about what the patient thinks and whether she, what say did she have in this? For her, it meant everything. It was validating. It was reassuring. It told her that there was something wrong, and it was actually stage 3 endometriosis at a very young age. So I think that that's a very important aspect for us to think about. Let's not forget the patient in all of our learnings.
I completely agree. It is about that individual person and what works for her. And putting a name to her symptoms validates what she's experiencing, so she does not have to wander in wilderness for a diagnosis for 6 or 8 or 10 years.
Exactly, and this should be implemented in every country, the developing country and the developed country. The protocol should be the same for the service of the adolescent endometriosis, and it should be our priority. So my last question to both of you, that is the quality of the life and the impact of the endometriosis on the mental health. Mostly we ignored it, and when we manage, actually, how can we make it more important when we dealing the patient from the family, when we deal with this type of the patient in our healthcare providers setup? So what is your take-home message? First, Deborah, you add, then after that, go to the loan.
Okay. Yes, well, this is an area where I have my own private practice, so it's very close to my heart. And thank you for raising it. It's extremely important that we don't silo the pelvis. In other words, it's the pelvis that we're treating. We're treating a whole person. And for that reason, I think that we actually we measure pain in our brain. So by ignoring and just putting the pelvis into a nice neat silo or a nice neat box and treating that completely disregards the importance of the whole person, her feelings, her attitude, what she's been through. Has she been fobbed off? Listening and taking careful history and acknowledging her symptoms and assuring her that you're going to do your very best to manage her symptoms and bring a resolve that she can at least have an improved quality of life. And also, as you say, most importantly, Doctor, is to protect her fertility down the track, if that is important to her.
Exactly, Madam Loon. Do you want to add in here regarding the quality of the life?
Quality of life has to be at the core of everything we do, because that is all that matters. So is that individual's quality of life? I think Deborah has summarized that beautifully, and that brings it back to the fact that we have to focus on the individual, what matters to her, and then develop a management plan according to her symptoms, her severity of disease, and her wishes. And that's pretty much all I can say, is to then bring in that holistic approach to address that individual person's quality of life.
I so agree, Lona. And sometimes, it's just saying, having that empathetic voice and that very first, that you understand and that you're going to have a little plan and that you can hear what she's saying. That means everything to patients.
Absolutely.
Yeah. Thank you, Deborah Bush and the Learn Here also, for your excellent and nice presentation. And you gave us a guideline regarding we need to early diagnose this sort of the patient, early identification, early investigation, early management, and overall the awareness program. It should be focused on in country-based, in school-based, and also the globally. Deborah Bush and the Learn, your contribution regarding the management of the endometriosis and the awareness globally from the ESB, we give you hats off, madam, for your excellent work. Thank you very much for joining with us.
Thank you.
Thank you. Thank you.
Now, this is the time we want to take some remark from one of our chairperson. It is my great privilege to call Dr. Hemanto Shenanaika, sir. Dr. Hemanta Shananaika, sir, is a professor of Emeritus of Obstetrics and Gynecology at the University of the Colombo, Sri Lanka. He is founder president of the Endometriosis and Adenomyosis Association of Sri Lanka and a member of the executive board of the Asian Society of Endometriosis and Adenomyosis. He is a very good friend of the Endometriosis and Adenomyosis Society of Bangladesh and the international advisor of HEASB. And with his strong inspiration and the support, we founded our society to serve the distressed endometriosis patient. Sir, would you please add your thoughts on presentation of two keynote speakers? Please welcome Professor Hemanta, sir.
Hemanta, are you there? I cannot see Hemanta here.
I think some connection problem maybe. When sir again will join, we will take sir. Now
Okay.
over to Professor Shaheen Rahman Chaudhary, madam, for the panel discussion part. Madam, from the panel discussion part, we can start with Dr. Mike because gradually Professor Farhana Dewan and Dr. Narendra Malhotra will join with us.
Okay, no problem. Okay, thank you, Sharmin. Now we'll move on to our second part of the scientific session, that's the panel discussion. Today we have three learned panelists from home and abroad. Before we start the discussion, it is my pleasure to introduce our three panelists.
I'm here.
Dr. Narendra will join with us, madam. So we can.
I've joined.
Okay,
Yes,
thank you.
Thank you.
So I'd like to introduce Professor Narendra Malhotra from India. He is not only very renowned in India, especially in the infertility sector, but he is a very old friend of OBGYN Society. He is the Managing Director of Global Rainbow Healthcare, and he is the Director of ART Rainbow IVF, and he's the Vice President of Suffolk, and he was past President of Foxy, AOGS, and many others. So on behalf of ESP, welcome you in this scientific session. Our second speaker, panelist is Professor Farhana Dewan from Bangladesh. Probably she will join soon. She is the elected president of Bangladesh Obstetric and Gynecology Society of Bangladesh. And she is the Deputy Secretary General of Suffolk. And she is head and Department of Gynecology and Obstetrics in Ibn Sina Medical College. And she is also Deputy National Coordinator FICO PPIUD project Bangladesh from 2015 to 2020. And finally, we have with us Mike Armour. He is the Senior Research Fellow in Reproductive Health. He is the Higher Degree Research Director and the Ambassador World Endometriosis Society. And he's the Chair of Australian Interdisciplinary Research in Endometriosis. So we will start with Professor Narendra Malhotra. My first question to you, sir. We know that the endometriosis is a chronic disease. It requires a long time management, and we have to plan with the goal of maximizing the use of medical treatment, avoiding repeated surgery. With this regards, there are a lot of debates with whether medical or versus surgical management for this problem. So what is your opinion, sir, about this regards? What do you think, why these debates coming? Also, I'd like to ask you, what should be the follow-up protocol for adolescent endometriosis? Over to you, sir.
So can I share my screen? Yeah, I'd like to show you
Yes, sir, you can share
slides on this. So thank you very much for inviting me here to this wonderful session on endometriosis, because the first two talks were just excellent, very, very good. And I would love to share this recordings with everyone in the who is not joined in here. Now, I've been asked to talk on what is medical versus surgical. Why is there a debate in adolescent? See, if that is infertility, if this is perimenopause, the debate is there. But whenever we're talking about adolescent endometriosis has to be treated and aggressively treated as soon as we pick it up. So the treatment has to be tailored to the individual adolescent. We just heard the staging. If there is an endometrioma, the girl will come with pain. If she's come before menarche, then probably we have to start thinking of the other etiologies, coelomic metaplasia etiology, etc. So not the retrograde menstruation and immunity. If you see an endometrioma, it goes to stage 3, stage 4, as ASRM says. And then, of course, for adolescent girls, primary surgery is required with a good surgeon removing all the cyst wall. And then followed up by the medical treatment. Surgery will improve her pain, will improve her school-going functionality, will improve her normal activities, and will improve her mental health and psychological aspects also. We all need to do a lot of counseling for these girls, for the parents, for everyone, because there is no cure for as it is for endometriosis. And that is important to tell them, and recurrence is common. But if the primary surgery in girls has been done well, and they have followed the medicines correctly, a scoring of pain at each visit, an assessment of treatment success at each visit. So all laparoscopies have to be therapeutic laparoscopies, not diagnostic. So it has to be done by an expert who knows endometriosis surgery and not by a normal gynec expert. Then all the visible disease has to be removed. Normal anatomy has to be assured. Adesolysis complete. Remove the implants or burn them with cautery, lasers, or completely excise them. Surgical treatment will provide great pain relief, but it should be followed by the medical treatment. And usually we'll record. What about medical treatment? Well, long-term medical treatment, pre and post-operative surgery, or primary medical treatment in the form of oral contraceptive pills, progesterone-only pills, transdermal vaginal rings. Of course, for adolescents, these are vaginal rings may not be suitable, but pain-relieving NSAIDs. Agonist and antagonists are used only if the girl is over 16, and should not be given early because it will just block the bone problem. Then the newer endogest, the progesterones, the norethisterone, the medroxy, the depot, the dihydro, or LNG US also has been tried in Grand Hotel. LNG US device, danazol and testosterone should not be used. But when I was reading the literature, they said transgender will benefit from danazol use and testosterone in endometriosis. So see, because that is what the future, we might get transgenders coming with pain. And then of course you should put them on the Japanese acupuncture, integrated medicine specialist. A whole team, multidisciplinary team should be talking to them, counseling them, and looking after their mental and physical health. How do we do a follow-up and prognosis? Pain scoring at each visit, which could be visual. Treatment success charting at each visit. How is she feeling? Has she resumed the normal activities? Has she not missing the school because of pain? And then we do imaging techniques to see for the lesions if they're there, and counsel or talk about breakthrough bleeding. So that would be my take on adolescent girls on a protocol on how to manage. We do not have to ignore the pain or the dysmenorrhea in adolescent girls, because it is seen that endometriosis to be diagnosed sometimes takes 6-7 years, because they go to the general practitioners, then they will land up with a physician, then they land up with a gastroenterologist, as Deborah was telling, and then they land up with a surgeon, and finally come to a gynecologist who's trained in endometriosis. So just like we diagnose ectopic, think endometriosis whenever there is abdominal pain, and even in girls. And if we neglect them, it can be a harm to their fertility. It can be a harm to their uterus. Adenomyosis might occur. All those things might occur. So that is how I would go about dealing with these girls.
Thank you, sir. Thank you, sir, for addressing very clearly about the various options of medical treatments. You highlighted about the long-term management plan and also addressing about the unique role of surgery. And at the same time, you just mentioned that about the alternative methods like acupunctures and other therapy. Obviously, if you look at the Deborah's and Lona's presentation, it should be a holistic approach, and where needed, multidisciplinary approach is needed as well. Thank you, sir, once again. May I now start with Farhana, madam? Are you there? Okay, so I'd like to ask Dr. Mai Karma, because probably Professor Farhana Dewan will join.
I am
Madam
here,
Joy.
Shaheen. I'm here.
Madam
yeah.
Joy.
Sorry, madam. Okay, so my next question to you, madam. We all know that you are Professor Farhana Dewan from Bangladesh. Madam, we just update our knowledge from Professor Malhotra. He was talking about the medical and surgical management, but we know that we should not really discount the lifestyle changes, like what to eat, how much physical activities to do, etc., along with this medical and surgical treatment. So I'd like to ask you, madam, is there any universal diet or modifiable lifestyle for prevention and management of adolescent endometriosis? Madam, please.
Thank you, Professor Shaheen, for a very important question. Can I share my screen?
Yes, madam. You can share. And by this time in the Zoom, 113 participants, thanks to the all participants. And in the social platform, we have more than 2,000 plus participants through the Facebook Live. Thanks for the joining, all the participants.
Madam, please.
In our hand, we also have the your presentation, madam. If you have any difficulty, Farzana will show it.
I think, Charmin, I had it, but I'm not seeing it in the screen. So can you just share it for me?
Yes. Farzana, would you please share? Farzana or Samrul?
Yeah. Thank you. Thank you very much. Next. Actually, next year. I'll not discuss about it because we know what is endometriosis. Next. This is the symptom and this is the prevalence. Next. So, next. So actually, we can think about prevention of endometriosis, but we all know that there are, actually it is not preventable, but we can discuss like if we talk about food, if we talk about diet and lifestyle modification, there is some. So studies suggested that citrus intake of more than 1 piece per day had a positive and effect and reduced risk of endometriosis, and higher total consumption of fruit and vegetable, they were beneficial. And it was associated with reduced endometriotic risk. And even then, it was found that when without studying every component with specific diet, difficult to know. So when we discuss about prevention, we must discuss in the contents of there being no definite data, but we will try to look for it. Next slide, please. In some diets, there are anti-inflammatory properties, but certain components of diets that can support the anti-inflammatory effect, and this is going to give some positive result, which has been studied and found. Next. So I will just touch on some of the diets and what it contains and how it helps. So we will talk about vegetables, fruits, fish and seafood, please. Fish and seafood, red meat, lean meat, poultry, egg, nuts, whole grain, processed food, sweet, and water. So regarding the vegetables, there actually vegetables should be taken. I know this is a big list and it is a bit elaborate, but people can follow it to some extent and we can advise them to. So it will be 4 to 5 servings per day. And what does 1 serving of vegetable contain? It contains 2 cups salad green and ½ cup vegetable, cooked vegetable. And where does it come from? It comes from dark leafy green vegetable, that is spinach, broccoli, cabbage, etc. And how does vegetable help? They are rich in flavonoid and carotenoid with antioxidant and anti-inflammatory properties. And it has been shown that vitamins including A, E, and C are lower in endometriosis patient. So it is good if the level is high. Next, fruits, 1 to 2 servings per day. One serving contains 1 medium-sized piece of fruit and half cup chopped fruit, 1/4 cup dried fruit. So I think it's not very difficult. If you can tell them, they can have it, and they'll get good result. How does fruit help? Fruit are rich in flavonoid and carotenoid, and these have antioxidant and anti-inflammatory properties. Next, regarding the fish, we all know about omega-3 fish oil. It is found in omega-3 oil. It is found in fish, seafood, and some seeds. They are also helpful, and 3 to 5 servings per week. Per week, they can take. That means they can take it every alternate day. And fish is rich in omega-3, which is anti-inflammatory. Next, red meat. Actually, red meat is not very good, so we should limit intake of red meat, and lean meat. 3 to 5 servings per day. They are lower in saturated fat and better control of cholesterol level. Next, nuts and seeds. 1 to 2 servings per day. One serving will contain 2 walnuts, 1 tablespoon of flaxseed. If people cannot take at least avocado, everybody knows. 1 ounce of avocado, and peanut butter is very easily available. So this can come from, it comes from almond, walnut, etc. And chia seed is also very important. And they are high in omega-3, which is anti-inflammatory effect. Next, whole grain, 3 to 5 servings a day. This is brown rice, basmati rice, etc. They have added B vitamin, which is important. And what about the dairy? Low-fat dairy or dairy alternative. 3 servings, that is per day. That is, they'll take 1 ounce of cheese, 8 ounces of serving of milk, 1 cup yogurt, etc. And this will also help, and they have vitamin D, which is shown to reduce pro-inflammatory cytokines, which are important for the inflammation. Next, processed food and sweets. This is processed food, fried food, fast food, caffeine. These are also sparingly used, and these are not very recommended. Caffeine, alcohol, they should be avoided. And instead, they can take dark chocolate. It is good because it has got, and frozen yogurt can also be taken instead of this. Next. So water, we all know about the importance of water, and I don't think I have to elaborate on it. Next. Next. So there are some food that may positively affect endometriosis: fibrous food and iron-rich food, and food rich in essential fatty acid. To fight inflammation and pain caused by endometriosis, it's best to consume a nutrient-dense, well-balanced diet. It's very important. I think that as far as I have discussed, we all know about it, and it's a matter of explaining to them and letting them understand the importance and taking it. Next. So it is very important to understand that regarding the diet, that it's not very complicated, but we should know how we advise them and how they take it and how they continue taking it and how they get the benefit. Next. Now I'll say a bit about the diet and the exercise, and that will be all. So physical exercise, it is important. There have been studies which have shown that when girls have taken 22 hours physical exercise per week, it has got good effect. And of course, there are also gymnastic, which helps because patients experience less pain and change in the menstrual cycle after beginning of the exercise program. And physical exercise increases the systemic level of various cytokines. And of course, the striated muscles have been recently identified as an endocrine organ, and through contraction stimulate the production and release of cytokines. So I think it's important to have the physical exercise, and it's important to make them understand, of course. Next. And this is my last slide. That a study has shown that beneficial effect of physical exercise on reduction of testosterone. So there are some, I think that I would have talked more about exercise, but I think I didn't. So other speakers can also, the other presenters can also talk about it. And that's all from my side. Thank you very much for giving me this opportunity. Thank you.
Thank you, Madam, for your excellent and very elaborative talk on diet and the lifestyle changes in prevention and management of adolescent endometriosis. You also highlighted, along with the right diet, you did mention that what are the diet we should be avoiding, like processed food, caffeine, alcohol, high fats, and should be advised for less fat. And also the focus on the exercise. I think this young group, they need this thing. And I'm sure with this diet and this exercise, whether you're physical or yoga, whatever, this should be really motivational for this young group. So thank you, Madam, once again for your very talk. Thank you, Madam. Now I'd like to move on to our final panelist, that is Dr. Mike Armour. Mike, as you know, so far, not even long ago, we used to thought that endometriosis is a disease of adolescents. But over the time, as medical research going on, we know that this is not the case. We know now all that this is a disease of adolescents. Even it can affect the prepubertal girl. Endometriosis is an enigma. We need to know more about it. We all now feel that there is unmet need of research for adolescent endometriosis. So from this point, what is your thought about it? Mike, please.
Thank you very much. I apologize for not having slides like a lot of the other members. I've also been unwell, but unlike them, obviously I wasn't tough enough to power through and do some slides. So you'll just have to look at my face, I'm afraid. So apologies for that in advance. So obviously, a lot of my research is in Australia, so I'll be discussing a lot of Australian data. But really, many, if not most of these statistics are likely to be similar, no matter where in the world you are. So what I'd like to do first is talk about the difficulties we have in researching adolescent endometriosis and why that might be, and then how we might overcome some of those difficulties. So I hope that will answer the questions. So we know from our research on people with endometriosis, they often report that their first symptoms occurred as little as within 24 months of their first period, so within a couple of years of their first period. So as Deb and Lona have said, amongst the others, you know, this idea that, you know, it really is endometriosis in adolescence. You know, it does start much earlier than we previously thought. But why is it, I mean, on top of the fact that obviously we have so little research about endometriosis in general, why is it so difficult to, you know, research endometriosis in adolescents? Well, as I think it was both Lona and Deb mentioned, dysmenorrhea is so common amongst adolescents, it's become normalized. I think Deb pointed out one of our studies where we found 71% worldwide. We have another one where we found about 92% of those in Australia who are under 25 reported some kind of dysmenorrhea. My colleague Melissa Parker has a very similar statistic. So it's incredibly common and it's become normalized. So many young women say they feel that their pain is just part of being a woman. It's just something they have to put up with. And this normalization of pain is, in my opinion, a very large barrier to diagnosing and studying adolescent endometriosis, because as we know, most of this pain is likely to be primary dysmenorrhea. And perhaps surprisingly, when we've done research on this, even primary dysmenorrhea can be moderate to severe. As a matter of fact, in our research, we found that amongst almost 4,500 young women aged 13 to 25, they reported an average pain severity of 6 out of 10, so a moderate or greater pain. So, and some women with endometriosis will have much greater pain, but some will have it in that kind of range. So it is much more difficult on dysmenorrhea pain alone to really be able to, you know, say, oh, this is endometriosis, this is primary dysmenorrhea. The other common symptom of endometriosis, especially, again, this is one of the things that we've been told in our research is one of the earlier symptoms. As Deb mentioned in her cohort, fatigue is one of the main ones, but also obviously non-cyclical pelvic pain. And around 83% of women with endometriosis report that they had this as one of their first symptoms as a teenager. But again, it becomes more difficult when we find that our research in young women in general show that about 50% say that they have some kind of pelvic pain at least once a month, even if they don't have period pain. So again, quite difficult to tease them apart. And then on top of that, around 50% say even if they have this non-cyclical pelvic pain, they won't go and see a doctor. They don't think that it's worth medical attention. And then finally, on top of all of this, around 53% of those at school said that they'd even heard of endometriosis. So all of these come together to be part of this diagnostic delay. 2.1 years in Australia between symptom onset and seeking medical attention. And then when you add around 5 years on top of that between presentation and diagnosis, you can see where this idea that endometriosis doesn't occur until the 20s comes from, because people have it in their teens, but they're not getting diagnosed till 20, 25 plus. So what can we do? How can we do more research on endometriosis in adolescents? So one thing we need is more longitudinal data. And I know Professor Sonia Grover was here before. I'm not sure if she's still here, but I know one of Professor Grover's studies is the Long Step project. And I'm not going to try and explain it too much because it's not my study and I don't want to stuff it up. But basically, one thing we don't know is what happens to adolescents who present with these kind of symptoms over time. And I think Lona showed in one of her slides, we really don't know what happens to endometriosis. Does it get worse? Does it get better? What is the outcome of things like menstrual suppression if we're using contraceptive pill in the teenage years? Does that change the pattern of endometriosis? Do things get better? Do they get worse? A lot of the time we really just don't know. So we really need these kind of long-term studies, 10, 15 years where we're looking at what happens in adolescence and tracking them through to see what happens over time. So that's one really big area. And I'd just like to go back to the importance of education during the adolescent time. So I know Deborah's talked about this, but I'm going to harp on about it as well because it is so incredibly important. And there are some tools that may be helpful which have been developed. So my colleague Melissa Parker at Canberra Endometriosis Centre has come up with a very simple 5-question tool called the PIPA tool. It's 5 yes or no questions. And just by answering this, we know from our data, only 11% of people score a 4 or a 5. And that means that they have the most significant negative impact. And in one of our studies, which is hopefully going to be published soon, we found that those with primary dysmenorrhea usually scored a 3, while those with a confirmed diagnosis of endometriosis almost always scored a 5. So this might be a simple screening tool to figure out who needs to go and see their doctor and encourage them, to seek further medical attention. And this can be built into any kind of adolescent education. So we have another study coming out where we looked at the effectiveness of just an online program. So this can be hosted by anyone in any country. What we found here was that, some simple information about what is quote unquote normal and what is not normal combined with the PIPA tool meant that almost half of our participants went to go and speak to their doctor. And then half of those again went on and got a referral to a gynecologist. And this was amongst a group which had already engaged with medical professionals in the past, but just empowering them with that information made them.
If you want to see what's on your schedule, just.
So the answer is really, we still need so much more data. I personally think looking at the impact of education programs is going to be important, and then collecting that long-term follow-up data to see what happens over time in those young women is going to be so important. So I hope that's answered the question. Thank you.
Thank you, sir, for your very thoughtful discussion on the unmet need of research for adolescent endometriosis. You really highlighted, because we by this time know that taking the history in depth, because endometriosis symptoms, a lot of time it merge with the normal dysmenorrhea, and also taking the history, how they're improving, whether the medical treatment is improving or surgical. So we need to keep the data on that. And obviously, I think with this data, we should be actually have research, not only limited to the nationally, but international level with the collaboration that might improve our knowledge and research, and so that we can overcome these progressive debilitating disease and raise our voice today with this year's slogan, Halt Endometriosis. Thank you once again. So I finally like to thank all the panelists for their excellent and very informative discussion and enrich us today with their knowledge. So may I now request Charmin to continue the next part of the session. Charmin,
thank you, madam. Thank you very much. With the permission of the Roshan madam and Gulshan madam, I'm just taking Professor Hemanto because he is in trouble with the network, madam. So I'm just taking, sir. Ladies and gentlemen, may I now request Professor Dr. Hemanto Shenanayaka, sir. Sir is a professor of the Emeritus, board member of the Asian Society of Endometriosis and Adenomyosis, international advisor of EASB, and sir is the former president of the Sri Lanka College of Obstetrics and Gynecology and the Perinatal Society of the Sri Lanka, and the founder president of the Endometriosis Association of the Sri Lanka. And the main thing is he's a real friend of ESB, and with his strong inspiration and the support, we founded our society to serve the distressed endometriosis patient. Sir, would you please add your thoughts on the presentations of the two keynote speakers and the panelists' thoughts? What is your thinking regarding the South Asian region adolescent patient dealing and the overall take-home message of today's webinar? Professor Hemanto, sir.
Thank you, Shamin, and I really must apologize for my inability to continuously join you, but it was due to a power outage. So I had problems in connectivity. But I really think the two keynote speakers are fantastic. Of course, they are renowned speakers on the area, done so much work on this area. But before I go there, I want to say again, and I have said this before, I really want to congratulate the ESB for the work you're doing. And I think I saw the slides that you showed, the pictures of the public awareness and the professional awareness programs you have done. I think that's really outstanding. I want to congratulate you. Regarding joining the Asian Congress, I will have some news for you next month. We are having another board meeting on the 3rd, so on the 2nd. So we will know something more about how to join the association, and I will be pressing for that. So you can depend on me for that. So talking about adolescent endometriosis, I really think Lona and Deborah did two superb talks here. I really think both from a diagnostic point of view, treatment point of view, as well as the genesis point of view, it's a very interesting area. Because as we've seen, there is an association. With the neonatal bleeding in girls, vaginal bleeding. Also, there is some evidence that there is some connection with the intrauterine growth restriction, and some researchers are saying that there are stem cells that will remain quiescent. They are laid in utero, and also they will remain quiescent until the menarche and puberty, and then get activated. So it's a very fast-moving, interesting area for further research, and from a basic point of view. From the Asian point of view, we have our girls have a big disadvantage in our cultural belief that painful periods is the norm. So I think we need to educate our parents, our teachers, our girls, that they must not accept pain. And I think that's a good theme as well for our future activities. Don't accept menstrual pain. So I think there's a lot of huge amount of education that's needed. And we were talked to about the ESHRE guideline, which is really fantastic. And it's very precise, it addresses all the aspects of this. And like was highlighted by Deborah, the hormonal treatments, hormonal contraceptives are becoming the first line. And I think we should not we should not shy away from using hormonal treatments in adolescents, and that it's important for taking it's important aspect in preventing progression of the disease. So once again, I want to thank you for inviting me to be part of this. I congratulate you again, and please accept my apologies for my not being able to join you throughout. But it's been, what I have heard is really been really very inspiring and exciting. So thanks once again.
Thank you. Thank you, Professor Hemantoshan Naika, sir, for your excellent talk. You are a real mentor to me, sir, and a real organizer. I always see you about the strong administration power to organize a big scientific conference and the Congress. Thank you very much for always guiding us. And with your inspiration and with your guidance, we are successfully run our society. Thank you again for joining with us, sir.
Thank you, Hemanta, for your nice comments. And
thank you, madam.
We are happy that at last you could join. Thank you.
Okay.
Thank you very much. And it is our great privilege that you give some hope as
stay,
that ESB can include in Asian society also. Thank you, sir. Now we will go for the remark from our guest. First of all, I would like to invite Professor Gulshan Ara. Professor Gulshan Ara is a Secretary General of our national society now, the Obstetrical and Gynecological Society of Bangladesh. And she is also the Secretary General of Pediatric Adolescent Gynecological Society of Bangladesh. That is a newly formed society in our country who are focused to work with the adolescent group of patients and adolescent group of people in our country. And she is also the editor of the Journal of the ESB, Office Secretary of the PCOS Club of Bangladesh, and the Organizing Secretary of Bangladesh Menopause Society. Would you, madam, add something regarding your guest of honor speech? Professor Gulshan Ara, madam, please.
Thank you, Dr. Sharmin Abbasi. Assalamu alaikum and very good afternoon. At first, I'd like to extend my sincere gratitude to Society Adolescent and Endometriosis Society of Bangladesh to organize this very, very important, nice and excellent webinar on adolescent endometriosis, because adolescent health is a neglected part, not only in Bangladesh, globally it's a neglected part. And our adolescent need more attention, more expansion of the treatment facilities, and more awareness program about their health problem. Deborah Bush, ambassador of adolescent endometriosis, nicely presented the about the shift in our thinking. Here we need shifting our thinking because our adolescent treated as a small adult people, not at adolescent. So we must shift our thinking about them for better treatment. And for early diagnosis, we need the clinician perception also. There is limitation of the clinician perception about the early diagnosis because it takes time to take the history, to take the risk factor of the family. So if we think in this way, we can diagnose this at early stage. And we should know the symptom, and we should, and there is very good medical treatment, which is Narendra Malhotra presented. They should know that. And Dr. Sharmin Abbasi also recommended the free medicine for adolescent girl for the treatment of endometriosis. This is very good proposal, and we should include adolescent health in the textbook of our adolescent, so we can improve the situation and condition. And about the food, which is nicely presented by Professor Farhana Dewan, our adolescents should know and should aware about the micronutrients, which is helpful for them to prevent endometriosis, and not only endometriosis and non-communicable diseases. They must avoid recreation drugs, alcohol, and others, and very high food, fast food. We should aware them about this. And unmet need of adolescent.
this is very big unmet need of our adolescent. We are not doing research, even basic incidents of that, pain during menstruation, menstrual hygiene, food habit of our adolescent, symptoms of our endometriosis. So we should do research in a broader way and very extensively. So if we follow all these things, which is recommended in this webinar, we can give our adolescent a better environment and better world for their living. Thank you very much.
Thank you. Thank you, the Honorable Secretary General of our National Society, for your excellent talk, madam. And your talk gave us some guidance for doing the particular way for the adolescent people of our country. Thank you very much for your hard working for our adolescent girls. Now I am taking our another guest, that is the special guest of today's webinar, Professor Roshanara Begum. Actually, no compliment is enough for her. And to the international faculty, I just want to mention about her that Professor Roshanara Begum working very hard with the adolescent group of women of our country from the root level. She is the Vice President of the Endometriosis Adenomyosis Society of Bangladesh, past President of the National Society of our country, that is the Obstetrical and Gynecological Society of Bangladesh. And now she is just chairing the two prestigious positions of our country, that is the Counselor of the Bangladesh College of Physicians and Surgeons and the Vice President of the Regulatory Board of the Medical Education in our country, that is the Bangladesh Medical and Dental Council. She is working very hard and full-heartedly and lifetime contribution towards the adolescent health in the root level to the urban level in our country. Please welcome Professor Roshanara Begum, madam, a mentor to me and also mentor to many of the juniors of our country. Please, madam, put the importance regarding the adolescent endometriosis. What is your thinking?
Thank you, Sharmina Abbasi, for your excellent remarks, actually. Thank you. Actually, we had a wonderful discussion. I was moved to the discussion, a wonderful presentation by our speakers and remarks by the panelists, and also what they have done in the whole world. Actually, from their presentation, we have now already understood that it is a silent and invisible neglected sufferings for the adolescents, and we are very much for the last long time. We were not feeling anything about this problem, because in our developing country, most of the mothers from the family always in front of our adolescents, they put a no, don't say anything about anything or problems. So it is a high time that we have all came out from this no, and now actually we the obstetrician take the steps to save our adolescents who are at risk of and who needs the treatment. We provide awareness program, and for the whole month we are working with this program. And for the awareness program, we provide we have to educate and train the medical community and to ensure early detection and adequate treatment for the teenage girls. Actually, they are very much suffer. They are not telling anything about their problems. So, and also to coordinate a worldwide epidemiological and socioeconomic study about the endometriosis and its consequences. When we are today from the discussion, we now came to the conclusion that we have to do something globally. It is an illness affecting millions, and now is that high time to invest in research and solutions to bring adolescents endometriosis out of the shadow and to the forefront of the global health and gender equality movement. And not only in the 30 days in this month, we have to do work the whole year is the 365 days. So I am not discussing anything about it because a lot of discussion they have given, and we are very much we are glad, and thanks to all the speakers, all the panelists, and for the organizer who are adding this program. And I think Dr. Sharmina Abbasi, Professor Samina Chaudhary, Professor Saraya Chaudhary, and we all will work together and to do something for our adolescents. Thank you.
Thank you. Thank you, Professor Roshanara Begum. Hats off to you, madam, for your lifetime contribution towards the women health in our country. Thank you very much for joining with us. Now, this is the time to take the remark from our president, the chairperson of today's webinar, Professor Samina Chaudhary, who actually make all the plan. How can we pass this March successfully? And Professor Saleha Begum Chaudhary, who coordinate all the programs of our society very successfully and give us the instruction, how can we move on? Professor Samina Chaudhary is the president of the Endometriosis Adenomyosis Society of Bangladesh. And she's the immediate past president of our national society, that is the Obstetrical and Gynecological Society of Bangladesh. And currently she is the chairman of one of the important hospital in our country, that is the OGSB Hospital and IRCH. She was the former chairman of the Endometriosis Subcommittee of the CEFOG and the member of the FIGO Committee of Human Rights and Refugee and Violent Against Women. My hats of gratitude to you, madam, because you were doing very hard work and always instruct us how can we move and how can do it. And also I want to give thanks to our Secretary General also, because she always coordinate everything very efficiently and with his strong leadership. So from ESB, from all the members of the ESB, I just want to give thanks to Professor Samina Chaudhary and Saleha Begum Chaudhary for your restless work. Now I'm just giving floor to Professor Samina Chaudhary, madam, the president of ESB, for the chairperson remark. And what is your take-home message, madam? Professor Roshanara said 30 days is not enough. We need to continue this work as a continued process. So please add yourself, madam.
Thank you, Dr. Sharmin, for the kind words. First of all, I want to congratulate everyone for making a very successful webinar. I want to give big clap for all of you. Dear Lon, excellent presentation. You have started with all the adolescents. Definitely they are still underprivileged group. And you have explained that way it starts very early and it continues throughout the life cycle. And the complexity of this disease, you have explained it very nicely. Thank you for the excellent presentation. About Deborah, the story of Jenny's, actually, it's a tragedy of a woman who are the sufferers of endometriosis. And we have seen that Jenny's story, it explains the physical and mental problem, but still there are problems with social problem that is not explained here, but we know there are many Jennies throughout the world. So we need to stand by the side of Jenny and we need to work hard for them. Thank you very much for giving us the highlights and your thoughtful explanation on that. About our Narendra Malhotra, he is always speaks excellent, and what he said, that medical versus surgical treatment, and explained it nicely. And in X-ray guideline, it has been shown that more on hormonal treatment, less surgery. This is one key words of our X-ray guideline 2022. I think we have to think before touching the ovary 10 times, because we know that there are problems with surgery, but surgery is definitely needed when it is very mandatory for it, but it must be in skilled hand. And we have to think that sometimes we need for this that multidisciplinary approach to treat this. And Professor Farhana Dewan about the dietary factor, still, yes, we need the healthy diet and exercise. That is a healthy lifestyle for all. And it also helps in reducing the endometriosis also. And she explained it nicely, but we need to work on it. And Mike, a good researcher, and what he said that definitely we have to find out what is endometriosis, where it begins. Still, it is an unknown disease to us. We need to work many areas on this issue, and not only it is not only the history taking and the examination, but we need to more on that, and we need to collect the data throughout the world. We need to find out really how we can prevent this, and is there any thing that prevents? Is there any vaccinations we can invent? These are few things. I think when Mike said, I thought like that. Once a day will come, we'll overcome endometriosis. And my Professor Gulsha Dara, she's the current Secretary General of OGSB, and she had explained it nicely for all of you, the explanation. And she always talked nicely, and I want to congratulate her also. And Professor Roshanara, she uttered a golden word. Why it is only a month of endometriosis? Why not every day is the endometriosis day? Because we need to work together. We have to combat endometriosis, and we must stop or halt the endometriosis, the progressive disease. We have to halt it. And last of all, what I want to say, thanks to all the speakers, all the moderators, Sharmin Abbasi and Professor Shaheen Rahman Chaudhary. And also I want to give thanks to Dr. Hemanto. He is, what I found that he is definitely, when I talk with him, I found that he is a perfect gentleman, and he always talks in wisdom. And I found a good friend of Endometriosis and Adenomyosis Society of Bangladesh, and I know him since the last 20 years. And I hope that we'll be included in Asian Endometriosis Society. And also I request to Deborah and also Lone, Mike, and really we want to work together. And if you have any scope of any research work or any thing you need to collaborate, we'll do it together. And I must say thanks to Nuvista Pharma, our Farzana Poppy, Tushar, and Samrul for giving us the assistance in technical part. And thank you all. I think we will again meet again and again. Thank you very much. We'll see somewhere. Thank you. I want to give a big clap to you.
Thank you, madam. Thank you for your excellent talk and your guidance, and thanks and gratitude to all the speakers and all the panelists. And there is a late night to Deborah's there, the New Zealand, and also in Mike. So I'm sorry for that, but thank you very much for joining with us, and remain with us in whole of the webinar. Now for the formal vote of thanks, I'm requesting my co-moderator, Professor Shaheen Rahman, madam. Would you please start, madam?
Thank you, Chairman. We are now almost at the end of our program. First of all, I'd like to thank our dynamic president of ESB, Professor Samina Chaudhary, for organizing such a wonderful and important webinar in this end of March month. With her strong leadership, ESB is working unitedly and giving services to the community. I also like to thank my special thanks to our another chairperson from abroad, Professor Hemantha, for giving us time and for his valuable remark and guidance in this occasion. My special thanks to Professor Saleha Begum Chaudhary, Founder Secretary General of ESB, for coordinating our team from the very beginning of this journey. Thanks to our keynote speaker, Dr. Laura and Dr. Deborah, for their excellent and very informative presentation, and also leading us to understand that we should serve this young group in a holistic way. My heartiest thanks to our special guest, Professor Roshanara Begum, and also to our guest of honor, Gulshanara Begum. In spite of their busy schedule, they have given us time and made this program successful. My special thanks to Dr. Sharmin, the Scientific Secretary of ESB, for her hard work to make ESB forward to reach the national and international level. Once again, I'd like to thank our panelists, Professor Malhotra, Professor Farhana Dewan, and Mike Arrow for their very interactive discussion. Thanks to all the EC members of ESB for working hard and unitedly for strengthening our society. I also like to thank to our OBGYN Society, all toward their support. And in fact, they're the one actually facing this challenging condition and supporting at the community level. My special thanks to Nuvista Pharmaceutical for their unparalleled support. Lastly, I must thanks to our audience. Without their presence, this program wouldn't be that successful. And finally, I'd like to end with this small word. Let's promise. Be her voice, learn, educate, and spread awareness. Thank you.
Okay, thank you. And my special thanks to Professor Saleha Begum Chowdhury, who is the Secretary General of Endometriosis Adenomyosis Society, and she is always with me, and Dr. Sharmin Abbasi and others. We work together always. So I think it's your effort that makes a successful program. Thank you very much. Thank you, please give a big clap for our guests and all the speakers, and also all our participants from home and abroad. Thank you.
Yes, many participants from the abroad. Sonia Gravier from Australia, and she is a very good friend of us. She also joined, and from the Japan, from the UK, and from USA, many of our international friends joined today. And it's an odd time in Bangladesh because it's a practicing time of the doctors. But at the peak of the presentation, there were 114 participants in the Zoom and 2,000 plus participants in the social media through the Facebook Live. So thanks to all. So with your permission, we just end our today's meeting. Thank you very much.
Just say halt endometriosis.
Yes.
Together.
Together. Okay, thank you.
Thank you. Poppy, we can stop the live, then we can personally